Hello, everybody. My name is Amanda Crosby. I'm the chair for the ICBP, and I'm here to talk to you today about the 2023 AMSEC standards and guidelines. First off, I have no disclosures for this talk. Today, I'm going to be talking a little bit about the background behind how the standards and guidelines are created, and then we'll review the changes to the standards and guidelines document. In the interest of time, the PowerPoint will only cover the major changes, and we'll only be talking about the adult version of the standards and guidelines, though there is a pediatric version out if that is relevant to your institution. And lastly, we'll be discussing some newly released resources to help you implement some of these changes at your institution. Within AMSEC is a committee called the International Consortium for Evidence-Based Perfusion. That's the ICBP. And this committee is made up of volunteers tasked with creating and updating the standards and guidelines for AMSEC. The ICBP committee writes the standards, but they are reviewed by the AMSEC board and other professional societies, and ultimately are voted on and approved by AMSEC members. That means you help shape these standards and guidelines, which is why it's crucial for us to always get your feedback. The ICBP published the first iteration of the standards and guidelines back in 2013. The standards and guidelines are written with three main goals in mind. One, to provide a framework for your clinical practice. The standards and guidelines are designed as a template for your perfusion team to follow and strive towards. Two, to define expectations. The standards and guidelines provides technology and conduct of care that institutions shall meet in order to fulfill the minimum requirements for safe cardiopulmonary bypass. And three, to reduce variation. The standards and guidelines help to standardize basic aspects of bypass, which are deemed necessary for patient safety. And within the document, you'll see two main types of wording. The wording and intent are different for standard or guideline. Standards have the word shall and are considered mandatory, while guidelines use the word should and are considered recommendations and may be helpful in helping implement other standards and protocols. The standards and guidelines are an important document for our profession, and we want to make sure that it's available to everyone. Everyone has access to it. And so I just like to remind everybody that it's free and open to everyone. You don't need to be a member. You don't have to log in order to access this. So how are the standards and guidelines developed? The standards and guidelines are a combination of expert clinical opinion and experience, that is from the ICBP, and is supported by evidence-based practice from clinical studies. Once a draft of the standards and guidelines is peer-reviewed, for the newest edition, we asked the American Association for Thoracic Surgeons, that's the AATS, if they would participate in the editing process. We included as well the American Academy of Clinical Perfusionists, that's the AACP, and the development as well. And this is the first time where we've had non-perfusion society input directly helping develop the standards and guidelines. And we did that because we believe it's important to have a broad stakeholder endorsement to support team-based review and implementation. So these are perfusion specific standards, but having a document you can take to your surgeon that's backed by the AATS, his or her surgical society, helps provide weight if you need to make changes at your institution. It's important to have buy-in from everyone on the team, and implementing changes at your institution will be easier if the document is supported by those external professional societies that are represented on your cardiac team. The document also undergoes a regulatory agency and regulatory review, legal review, as well as gathering feedback from the perfusion community. And I'll talk a little bit more next about that community feedback. And after all this input, we end up with a final draft that's put to vote by the AMSEC membership, and then if approved, becomes that final ratified document. And it's all these elements that contribute to creating that final standards and guidelines document that I'll be talking to you about today. So over the past 2 years, we've asked the community for feedback on the standards and guidelines in the form of 4 different 1-hour webinars, an open-ended question survey, and presented the proposed changes at 6 different conferences. And from those 2 years of feedback, we received over 250 comments and suggestions. All of these edits were individually reviewed by the committee, resulting in several hundred hours of work and revisions. In total, there were 49 changes to the Standards and Guidelines document. 29 edits were made as a direct result of the community input. And as I mentioned to you earlier, this 2023 version was collaborated on and endorsed by the AATS and the AACP. So I want to show you where you can find the new 2023 Standards and Guidelines document. So on the AMSECT homepage here, if you hover over the Policy and Practice tab on the far right, you'll see a drop-down menu which will appear, and then you can select the AMSECT Standards and Guidelines. Just a reminder again, you don't have to log in to see any of this information. They're free and open to everyone, not just AMSECT members. So after you click that Standards and Guidelines link, this page will appear. The first link there in blue is for the newest version, the 2023 Standards and Guidelines for Perfusion Practice. Directly below it are the pediatric version and the mechanical circulatory support versions, if those are relevant to your practice. This next link is for our frequently asked questions document on common questions we get about the Standards and Guidelines. And down at the bottom is our implementation toolkit. This is where you can find additional resources to help with the implementation of some of these new changes. And we'll talk about that a little later in the presentation. So this is standard 1.1. It's the cornerstone of the document. It wasn't changed at all in this version, but I wanted to show you because you'll hear me mention it several times today. And that's because this standard helps to avoid us getting too specific in the wording for other standards and guidelines in the document. We often rely on this concept from 1.1 that allows your institution to further define the specifics within the standards and guidelines. So this is the start of the new edits. We'll go through several of these individually, again, but not all 49 in the interest of time. Everything you see in red font for these slides are the changes or additions. So sometimes that's just a few words. Sometimes that'll be the whole standard or guideline. This first change is the addition of standard 1.3, which talks about accessible emergency protocols. In order to best serve the perfusionist and increase patient safety during an event, emergency protocols should be readily available, whether that's in a book in the pump cart next to you, or that's hanging up, laminated on the pump itself, or accessible via your intranet. That's all up to your institution to decide. Also, what you want to define as emergency protocols, also up to your institution. Next is standard 2.5 regarding sufficient time for orientation and onboarding. This standard was made to ensure adequate time for training staff members to avoid the tendency to rush the process and put someone on call or alone too early. This is simply a patient safety issue to guarantee that any perfusionist, whether new grad or PRN, has had the proper training at your institution to handle any responsibilities or emergency situation. This next change is the movement of a guideline into a standard. So that means moving from a recommendation level to a requirement level. This new standard discusses post-op debriefing. The pre-op debriefing is already a standard, and this change makes post-op debriefs a requirement. Post-op debrief can be done during chest closure, doesn't have to be overly lengthy or formal, and should be an opportunity at the end of every case for anyone in the room to voice concerns, questions, or improvements about the case. It's important to note, I think, that debriefing is probably already likely occurring in your OR using the criteria mandated by the World Health Organization, the WHO, and it's supported by AORN and the Joint Commission. So we just want perfusion to be involved in this process just like we are for the timeouts or the pre-brief. Accompanying it is a new guideline that expounds on the standard, listing possible topics that could be included in your debrief discussion, such as issues that occurred during the case, problems with equipment, disposables, or changes to protocol. And the debrief can also serve as an opportunity to discuss the positive events, good catches, or things that went well during the case. This next revision is another move from guideline to standard. This standard discusses monitoring arterial flow distal to all circuit shunts, and moving it to a standard makes that a requirement. Depending on the number and type of shunts in your circuit, the deviation from pre and post shunt flow could have an impact on your delivered patient flow. And knowing the true flow to your patient is crucial to delivering quality perfusion at all times to every patient. This is another proposed move from guideline to standard. This requires DO2 calculations to be utilized to optimize gas exchange. Please note that this does not specify recording the values or mention the frequency or how often this has to be done. This is up to your institution to decide. There's also no mention that it has to be done by electronic monitoring or require a special computer or monitor. A DO2 chart, such as the one pictured, can be used to quickly and easily reference your index DO2 on bypass. This chart can be found on the website in that implementation toolkit section that I showed you earlier. This is a rewording of Standard 17.1 that currently discusses perfusion participation and quality assurance and improvement programs. The additional wording would support the use of safety reporting structure and incident reporting. The aim here was to encourage centers to cultivate a safety-focused environment by promoting safety and incident reporting. This is a rewording and move of Guideline 17.1 and 17.2 into a standard, which requires perfusionists to collect data to advance quality and safety. The rationale here is that if perfusion programs hope to improve, benchmarking and data collection are required. Note that this standard does not specify the type of registry or database. It can be national, state, or even at your local institution level. This edition is part of the new Section 19 on crisis management to ensure that perfusion departments are ready for hazards and unidentifiable risks. The standard allows perfusionists to collaboratively form a crisis management plan within their hospital in advance of an event to help prepare for sudden changes that may inhibit the ability to perform our standard duties. This standard and the following 5 accompanying guidelines are aimed to help the perfusionists prepare for unforeseen circumstances that may interrupt supply chains, affect operating rooms, or create a shortage of personnel. The important part is to develop a plan with your team now that's written and accepted before a critical event occurs. This is Guideline 19.1, which suggests that identifying alternate vendors to address potential supply chain interruptions. I'm sure this is something everyone here has had to deal with or been affected by, and having preemptively identified an alternate vendor or possible substitutes for your disposables could help if those items go on back order or become available. This doesn't mean having to purchase or stock additional supplies, only that identifying or creating a list of alternatives in advance is recommended. This could allow you time to identify any differences in the substitutes, find the differences with your surgeon and your team, and maybe even try out some demos. 19.2 discusses identifying alternative areas for storage and preparation should a catastrophic event compromise the primary areas. The rationale here is that having identified alternate storage area and setup areas in advance of the incident could help reduce confusion, delays, or lost or missing items if your typical storage setup becomes unavailable. Do you need to consider areas with certain ventilation? What about temperature monitoring or humidity management? For your sterile items, you'll want to identify all this before a problem occurs. 19.3 discusses identifying alternate rooms that can accommodate a heart-lung machine in the event your routine rooms are not available. Knowing which operating rooms or facilities could be suitable for extracorporeal support may be helpful to prevent delay of procedures when typical rooms are unavailable due to a crisis event. Items to consider such as negative or positive pressure rooms, adequate gas and air hookups, vital sign monitors, and outlet availability and with the appropriate wattage. Just some things you want to consider before that crisis occurs. 19.4 involves preparing a patient evacuation procedure to help with evacuations in an emergency situation. Having a protocol established for how and where to evacuate patients currently receiving extracorporeal support could help increase patient safety and reduce confusion during an emergency. Your hospital very likely already has a plan for emergency events like fire, active shooter, or compromising weather, but where do you where does perfusion fit into that hospital disaster plan? Have you discussed with your staff where you'd meet if you had to evacuate for a fire? Are you supposed to help with patient transfers? Who stays behind in an emergency situation if needed? Again, these are discussions, things that you'll want to consider when you create a plan in advance. And finally, 19.5, which covers giving consideration to clinical expertise and proper role assignment if perfusion staff repurposing is required for an emergency. And this guideline is just meant to safeguard perfusionists from being repurposed to tasks that are incompatible with our training or expertise. So in release with this standards and guidelines document, we have released several resources to help with their implementation. And so I'm going to run through these briefly. First, the frequently asked questions document, which I showed you the link for earlier, that provides answers to some of the commonly asked questions we received about the standards and guidelines. So any topic that was asked about multiple times or had several comments, we provided answers to those questions. So if you're reading the new 2023 version and you have a question, you might try looking there first for some clarification. We also created an onboarding template to help with the new standard 2.5 on training and new hires. As I mentioned before, the standard was added to prevent new hires or PRN from being put on call prematurely or in an unsafe environment. So the document covers topics to consider when creating your own orientation plan, like staff and location orientation, especially at night. Do things change after certain hours? For instance, do you have to use the main pharmacy now, or do you have a satellite pharmacy? Do you have to use the Pyxis? Do you have credentials for that? Have you tried your badge at different hours, after hours, at all the department doors you might need? Again, these are just suggestions and part of the template if you're looking for a place to start when creating your own training protocol. This resource is to help support standards 7, 9, and 10. It's an Excel spreadsheet that provides formulas for pre-bypass calculations like dilutional hematocrit. You can fill in the highlighted areas there with your patient-specific information like height, weight, baseline crit, and your circuit prime volume, and the formula will calculate your expected dilutional hematocrit. A DO2 chart is also included that helps estimate your index DO2 on bypass without the need of a calculator. Or additional resources. There is also a standalone chart on the website for you to print off if you just want the DO2 chart. Because again, you don't have to have new equipment or memorize the formula and pull out your calculator and spend time on bypass doing this calculation. Just find your current hemoglobin with your cardiac index, and you can quickly find your estimated index DO2. We also have a supply management resource to assist with a new Section 19 on crisis management. It provides suggestions for determining backup items, what to consider when setting PAR levels so that you have adequate supply without having wastage. And again, this is not a standard, just a template for your own use if you're looking for some support in these areas. If you have any other comments or feedbacks about the standards and guidelines, about our frequently asked questions, anything you'd like to add, or about any of the resources that we've released in concert with the standards and guidelines, please feel free to email me. You can use either email address. They will both reach me, and I appreciate your time.